All right, so let's get started. I want to welcome everybody to our final session of this national training series on reducing risk for child maltreatment and treating its consequences. Our final session today, session 6, is on translating predictive and causal knowledge to realize their potential. So, really kind of pulling everything together and then some of the practical implications of that, with a particular focus on some of the tools that you can use or can think of using for actually translating causal knowledge into the application in the real world. Next slide, please. All right, so just as a recap, as we always do, the slides will be available after the webinar. Um, Glenn has also included some of the recap slides in here, which will be really nice. We're not going to go through all of them today, but they're included in the file. So it'll be a nice slide deck that kind of gives you a nice summary of all the work we've done up until now. And again, this training is being recorded, and we will send that out to the slide with the slides to everybody who participated and also who registered for today. So you can have that. We've also recorded all of these, and we'll be sending out the links to all of these, all 6 of them. So if you've missed one or you want to pass them along to colleagues, etc., you're welcome to do that. And I believe with that, I'm going to pass this on to this is the executive team of the Champ Center. And with that, I'm going to pass this on to Dr. Sachs to get us going today.
Well, thanks, Andy, and welcome back, everyone. It's our last time together, at least in this series, and at the end, we'll be talking about your interest for continuing at some level. But today we're focused on a really important topic. It's about how to make it real. We've talked all about causal modeling, predictive modeling, models in computers, but how do we bring it into the field to help people? And that's our focus today. So here are some of my disclosures. And then I thought we'd start by reviewing key concepts. What I've done before is review last week, but we've been together for a while now. We're ending this series today. And so I want to just talk about where we've come to build for what we'll talk about today. So our first session, we started with the massive problem that we all know about. These numbers, not going to go into them in detail. Then key definitions of prediction and causation. You've seen this many times. You know what it means, but we really grounded everything in these definitions. And then we talked about why causal and predictive is very different. And everything was grounded. You've seen in this slide how to see the future. We take our clinical data, and there's only 2 decisions that need to be made. Is she at risk? What can I do to reduce the risk? So everything turns into this. The massive complexity that we all work with ultimately boils down to this. Oops. And then we really focus this training series first, grounding it in people. What is needed in the field, in clinical care, in practice. And so we dove into that in session 2 with talking about the clinical process, starting from assessment. What do we assess? How do we make these 2 clinical decisions? And really, they're decisions about future outcomes. And how do we use our predictive and causal knowledge in order to do that? Because clinical work or any practice involves prediction and causation, whether we have the science to back it up or not. And so we focused on one kid. We remember Eddie. We really applied this to Eddie, the whole clinical and predictive process there. And we talked about this cycle, which is so important. The essence of practice is predicting under intervention conditions and improving practice based on results if they're other than what you predicted. And that's like basic. And we talked about some of the problems with the diagnosis we use and looked at how medical diagnosis works. And with this, we then talked about if it's green, you can intervene. If it's red, get that out of your head. That became a very important part of this. And then we talked about the problems with practice, but then we talked about solutions in 3, where we talked about different practical approaches. Um, if we understand when traumatized or maltreated kids typically come to care, it's all about their repetitive expression of episodes where they can't control emotion and behavior that someone, the child or someone, regards as important. So with that, how do we predict under intervention conditions that this dysregulation will be improved? And that's really the essential thing. And it's all about causal questions. The book of Why is by Judea Pearl. It's not a clinical book. It's a book about the science of causality and the math of causality, but why is the question here clinically always? And I gave the example of our treatment, trauma systems therapy, which is based on predicting under intervention conditions, and looked at Eddie and how Eddie's clinical problem, these episodes of dysregulation, might be helped based on why he gets dysregulated in certain moments. And then we talked about a tool that we use for Eddie, but could be used anywhere where you do your assessment, then you think you know what's going on enough to intervene. So you're predicting that things less episodes of dysregulation, the episodes will have less functional impact. And then what you do is you check after you launch your intervention, were your predictions accurate? If yes, keep going. If no, then you need to rethink, are you missing anything? And so the whole idea of prediction under intervention conditions, as we talked about, is key for clinical care. That brought us to looking at our science and how science can inform practice. And it maybe was more of a depressing session because we talked about this seemingly impenetrable translation wall. Because if you look at the thousands and thousands of scientific findings, and then you look at how many of them are actually used in practice, it's a wall, and we have to break through this wall. We have to scale this wall. We talked about the paper we wrote that we call our manifesto with the causal exclusivity thesis. Outcomes can be systematically improved through intervention on their causes and in no other way. A health field without the tools to distinguish causes from non-causal correlates and without a diagnostic system to encode this distinction cannot advance. And that's a kind of something we think about a lot. A lot of our work is based on this and how to make it different. I gave examples of 3 of my mentors who are fantastic scientists, incredibly productive, all of that, but they died without much of their work, or sometimes any of their work, translating into routine care, even though that was their dream. And so we have to think about what are we doing, and put out there's only 2 conditions for which we could scale this wall. One, the scientific findings have to be causal to reveal how to improve outcomes, and diagnostic classification must be causal to apply a finding to a particular child. We talked about etiological heterogeneity, many causes have serious implications for how we use our diagnostic system, and then talked about the triad here: causal discovery, diagnostic classification, intervention targeting, is part of a learning system to get better and better and better as necessary. And then last session, then we talked about how to use methods to enable this. So I talked about several principles of causal data science, from basic things that we're trying to, there is a causal process generating the data that's used in our research, so we have to discover it. And talked about how randomized controlled trials, which generally cannot be done for etiology, how we are able to infer causes, and how that same thing can be inferred from causal methods without experiments. And then introduce causal data science, basic ideas of the steps of causal data science, so you have at least a conceptual view of how it works. And then introduced one application, what we've been working on, about a study of maltreatment exposure and causes of it. I presented our findings on that. Today, what we'll be talking about is how to use those findings to build a clinical decision support tool, because that's today's topic. And that brings us to today. So today is so important because this is where it comes together. It's, if we're going to have these models, it's one thing to be publishing them in literature, but if we stop there, it does the same thing as all the thousands of articles, because it doesn't really matter unless findings can be used in the field to enable prediction under intervention conditions. So that is where we are today. And so what's our goal today as we wrap up this training series? So the challenge of making science practical, because as we're working and building decision support tools and trying to think through, bring them into the field, there's a zillion things that need to be thought about to make it work. And so we'll be sharing our pain with you today about making this work, so you could think about how you might, if you might think about contributing to decision support tools, etc., and help us even think through some of the challenges and dilemmas. Talk about certain ideas about designing tools. Review an example of our tool, like from the findings I told you about, and also to talk about other examples in the field. And then, sadly, we are wrapping up, and so we'll end and really want to get your ideas about your experience and how we might think about the next training series. So I reviewed this at the beginning, but again, it's all about this. It's all about these two things. So in the first session, I talked about this crystal ball, because it's all about seeing the future about these two things, but let's not rely on magic. Let's build tools that can help us to do this. Again, clinical work is based always on our own sense of how we predict, and our sense of what causes what. But good clinical care is always about that. There's no alternative to that, but let's try and make our science more informative about that. And that's really what our goal is here with getting these tools together. And again, we've gone over this, but the need for science, that brings it together. So, this is brought to you from the Champ Center, and I want to just talk about how our core value fits here, that it requires real collaboration, not just collaboration for show. It involves experts, all stakeholders together who understand the real world, so we could really get this right. And in the Champ Center, we're certainly working with a broad range of people to be able to do this. So it's not only data science, clinical scientists, clinicians, administrators, policymakers, youth, families, all of that, everyone who has a stake. So some ideas about designing these sorts of tools. So the first part of it is to define its decision support tools. So what sort of decisions do you want the tools to support? By what sort of decision makers? Who's going to make the decision that's helped by the tool concerning their actions or interventions on in what sort of individuals? Again, it's about this. So the decisions should be based in some level on these two things. And so we have to think carefully about the population and what they need, and who is the decision maker, the practitioner, the caseworker, the pediatrician, the mental health clinician. Who and how do they work? We have to be thinking about that. And so then what goes into the tool? What knowledge needs to be programmed into the tool? Because the tool is going to give recommendations. It's going to take as input some sort of data from people, clinical data, et cetera. It's going to process it and then make recommendations on who's at risk and what you do. So where does that knowledge come from? What research findings? And is it good enough? So you search the literature, say for predictive findings, and then you have to think about, well, what's good enough prediction, and all kinds of trade-offs, like false negatives, false positives. Like for certain things, let's say it's maltreatment exposure, a false negative is pretty bad and a lot worse than a false positive, right? So you have to be tweaking things based on that. You don't want to miss maltreatment exposure or outcomes like suicide. Also, you have to prioritize, not wanting false negatives in these things. So all these things need to be thought about. And then what about how many features are they measurable in the world? So you might get, based on a research finding that has 1,000 different features, and then you're going to need to be measuring that in the world. So they have to be measurable. And then causal results, how confident are you? Is there confounding? We talked about that. So are the methods strong enough? What would be clinically significant? What would be a meaningful effect? Have to think about it. And then, of course, okay, you have a cause with a large effect, but are there interventions known to be effective for the causes? Because if they're not, then an intervention would need to be designed or developed or whatever. So all of these things need to be thought about. And then, is a cause measurable in the real world in typical care settings? We have to always be thinking about that. And then let's look carefully. You have a research sample, but you have the intended population, and can it go to that population? And so you have to decide when you look for knowledge out there, scientific knowledge, is it sufficient? And if not, maybe you do your own research study by collecting your own data, or what we are doing is finding very large data sets that seem to have the information we need, and then using the right sorts of methods to rigorously bring out predictive and causal knowledge on outcomes we think are very relevant. So the study design would be, collect data or find a data set. We have to look at all the features in there and are they plausible for guiding the decisions? And are we using the right methods to obtain this? Because all of this comes to models that end up being programmed into the tool, being translated into decisions. Okay, so then let's talk about the design of a tool, how research findings can then lead to decisions that would be programmed into the tool. So there are data sets which, that whether we collect them, look at them, have to be prepared so that we really understand what's in them and they're really relevant. Predictive methods where we're really quantifying the level of risk based on all the features, all the variables in it. And one thing we use is in Markov boundary feature selection gets the most parsimonious prediction, the strongest prediction with the smallest number of variables so that it could be as clinically relevant as possible. Our causal methods, we're then looking, remember, prediction isn't causal. So we're excluding confounding to find the direct and indirect causes. We're finding, is there more than one model that's consistent with the data? Let's really look at this rigorously. And then most important, to estimate effects with as little bias as possible, preferably unbiased, because that gives you confidence that if you intervene, it's going to change something. And then stakeholder and expert input on such things as you look at your models. Are there large enough effect sizes? Are they measurable? Are there available interventions? Large enough prevalence in the population? So all of this has to be thought about and then programmed into a tool. So it really involves like the right data, the right methods, a lot of wrestling with it with experts and people in the field, any stakeholder that, it's all about value and use in the field. So tool essentially is kind of 3 steps to do it. There's input. So whatever you've arrived at with predictive and causal variables, that needs to be assessed with people, people you think will be at risk, that sort of thing. So you have to have an assessment package that then takes in the data, and then a tool takes this as input, processes it in real time, and gives you output. And this is the sort of output needed. Is the child at risk? Yes or no, or how much risk? Need for intervention. What interventions should be recommended? And it would spit out the for the data, for the information the child and family provided, what interventions would be recommended, and then it spits out the risk without intervention. What is the reduced risk you would get through the interventions that are recommended? And again, this is the sort of tool that we're aiming for. I'll talk about most tools, or all tools in the field now, are essentially risk tools because they're based on predictive information and analyses and that sort of thing. One thing where we believe is so important, that's a key theme of this training series, is you need causal knowledge in order to recommend interventions. And that's how we're trying to advance the field, through tools that are able to do this. And just to give you like an example, let's say you had a causal model for self-destructive behavior from sexual abuse that looked like this. Assume that the size of effect for all the causes were significant enough to want to intervene. So basically, you would think through and hopefully get input from stakeholders and experts and all of that. So what interventions might you come up with for each of these causes to reduce the risk of self-destructive behavior? So, I've just made this up. You put this down, so you're looking for different interventions that might be out there, and you're wrestling with the team of expert stakeholders, all etc. I've talked about that, to come up with this. And then the tool is programmed. If someone gives you information about any of these factors and it reaches a certain threshold value that you might program in, then it will say, yes, this is an intervention that's needed. You could also do it with continuous variables, but ultimately a yes and no is how these tools best work. So if someone endorses on a scale like significant impulsivity or significant or a recent loss or whatever, then given the input you get, then the tool is programmed to spit out that recommendation. So again, this I've said this several times, but these are some of the things that groups of people with knowledge of the real world have to wrestle with. So just some basic things that have to be considered. This repeats some of what I said, but not all of it. So how closely, you basically, you have two groups of people. One is the group of people you want the tool to apply to, and the other is the group of people in the study or studies that you use to derive scientific knowledge to program the tool. So you have to think about, because no data is going to be perfect for the population you want to bring this to. In fact, there's often a big differences. So it's another big trade-off. So you have to be thinking about how closely does the tool's intended population resemble the samples in the research studies? What proportion of the tool's intended population can be helped by the tool's recommended decisions? So if you're selecting a few causes, what proportion of the population will this be relevant for? And we struggle with that a lot as we design our tools. And then we need to figure out measurement. So practical measurements. So in studies, these factors were measured in certain ways. Is that how things should be measured in the field? And if not, what are the risks of doing that? And then you're going to select factors that may not be all the factors in your predictive tool. So what will that do for your predictive performance? You're going to have to choose causal factors. Which ones would you choose and why? And then there's going to need to be decision on how programmed, how different ones might fit together. Now, this is based on a causal model that you would have, but there's all kinds of specific decisions that go into that. And then again, you're going to have to choose for a cause an intervention that's available out there. And then you have to think, what does the literature say on its potency? Will it completely change the cause, or will it change it by 25%, by 50%? And then that gets programmed into the expected improvement you're going to get from this, from intervention. And then, of course, the iatrogenic consequences of the intervention and causal factors. In other words, are you thinking through the potential harms that can come, the side effects, the risks, all of that? So now as we're doing this, we're always thinking about who it's going to. The idea who will be using this tool, who are the decision makers who will take the recommendations and then work with the child and family. So who will administer the tool? Again, is it like a mental health clinician, a pediatrician, a child welfare caseworker? How much does doing this deviate from their usual workflow? Training. There's going to be an assessment package, as I've said before. Is it practical to use in the field? It's going to make recommendations on decisions. And how much does this deviate from decisions that practitioners would usually make? Because we then need to think about that carefully, about whether this is actually going to be used. And, one thing important is, like, are they able to make the decisions? Let's say you have a tool that you're recommending 3 different interventions, but the practitioners have no access to that, no training in the interventions, or the interventions are too expensive, too difficult for them to use. So your tool isn't going to be very practical, because they'll make recommendations that they'll only wish they had access to be able to use that. So when we think about choosing causes and interventions, we have to think about the interventions that are available to people. And then, of course, most importantly, the needs of the people that will be subject to the decisions, and especially ethical concerns in the design of the tool. So how closely do the recommended decisions correspond to individual needs? So we may design a tool based on, like, expert assumptions of what people need, how the decisions will influence their life. But we need to include in a group of people informing us about how we design this, including, family members, people who are going to be, subject to this tool, so that we can really understand. And then the assessment process, if it's involves a 3-hour assessment, is that really going to be practical based on the people that need to be assessed? Whether, I've talked about this before, for these individuals, whether the risks and benefit. Here's something important, like what's the level of certainty, confidence in the recommendations? There's, you know, the models that are built give us information on the degree of certainty and the confidence we have. So how must this be programmed in? Because if it's going to guide a decision, depending on what the decision is, we want to know how confident we can be. And again, what are the plausible harms? And then once the tool is designed in this way, we want to test it in the field to see if it works. In other words, the recommended decisions cause the expected benefits without undue harms and all of that. And then that's a whole nother thing that, in fact, the tool will be talking about. We're taking into the field, and there's so many things to consider then. So, what I'm discovering is one of the reasons I think that people are not designing, tools for models to be brought into the field, um, is it's easier to just stick with the computer and publish papers. Actually thinking through the detail to make this work so that scientific knowledge can translate into clinical care, which is our overarching goal, is really hard. And nothing, and so, we have to build the tool with all that thoughtfulness and then test it in the field in the right way. So just some examples. Now, there's not a large literature, but there's some literature, and I just want to, I'm not going to review everything, but I'll review some things, and then I'll talk about our process for building our tool. Maybe I'll stop. If anyone has any questions or comments about anything I've said so far.
And if you have any questions or comments, you can either jump in or throw them in the chat.
Anything?
I'm not seeing anything in the chat.
Okay. Okay. So this was a review, or a systemic scoping review of what's out there. And it's a great article because it's very thoughtful and rigorous. It's, the senior author, Emily Putnam Hornstein, is on the Chance Center advisory board. And they're putting together, and here's the questions they asked for this study. Is they want to know what tools are available or used by child protection agencies that have been evaluated in the literature. And then they're saying, what is the reliability and validity of the tools and potential biases? So that's really interesting because we want to know this. So basically, they surveyed lots and lots of articles and found 25 articles of tools that fell into 11 what they call tool families. 4 of them were consensus-based tools, and this is not necessarily driven by data and research, but basically driven by committees with clinical judgment, informed by theory, expert opinion, group decision making. 6 were what they call actuarial, and this is based on research, empirical evidence about maltreatment risk. So it's, programmed within, risk information from research studies. And only one was automated algorithmic, which is consistent with what we do in some ways. It's, similar to the actuarial, which is empirically oriented approach, but uses sophisticated data-driven methods to produce a risk score based on large administrative data sets. So they're focused on child welfare administrative data sets, and using methods. But one thing is the methods used are entirely predictive. So the risk score is about, is the child at risk for, a maltreatment outcome, risk for maltreatment, but not about causal factors that reveal promising intervention targets, which is where we're trying to bring the field further. But further, I mean, in this study, only one study, it was based on more sophisticated data science methods, which we've been talking about. And, the conclusions were not very conclusive. I mean, I'm just reading two things. Overall research about validity and reliability of the tools is very heterogeneous in methodology. Conceptualizations of risk assessment operationalization of risk all varied widely. Generally, there was a dearth of evidence support use of tools across demographic groups, heterogeneity of studies, assessing reliability, validity, says lack of agreement on the assessment of tools, very difficult to interpret findings across studies. And so these, the implications is for child welfare agencies, and the conclusion is to be cautious about the over-reliance on tools because the evidence is very limited. So for me, it's kind of good to get something like this about the state of the field. Now, but then there is that one tool, and I want to talk about that because it's very interesting. And this is the author's published in JAMA Pediatrics. And this is a study of taking a tool, and I'll talk about it, looking at risk for maltreatment, and then in a very large data set, and then how that's reflected in, they had data about emergency room visits for injuries. So interesting. So how did a tool predicting maltreatment, how is it reflected in injuries in youth? So it's a big data set, over 47,000 kids, classified with tool that's used, probably the most well-known tool, the Allegheny Family Screening Tool for maltreatment risk. And they had linked data for hospital ER visits for injury. They had injury called possible maltreatment, and then self-inflicted injury. So it's a really, really interesting study. And just to say a little bit about the Allegheny Family Screening Tool, it's basically about when a report is made about possible risk, possible maltreatment, the screening tool is used, and then their outcome is predicting, like, will this end in foster care placement? So, it's really predicting maltreatment. And the tool itself was based on administrative data with 673 features on a lot of families. And basically it selected 118 variables, and its predictivity was pretty good, 0.78 for sure. And so it's been used a lot. But then the question here is how will it predict hospital injuries? And so this is the data table. And so I just want, if you folks look first at the all children, they're looking at those who got the highest score in the top 5% versus everyone in the lowest 50%. And you could see that this is injury encounter per 100 people. And so if it's an injury from any cause, the highest, it was 14.5 out of per 100. But if it's the lowest 50, so this is, prediction for any sort of injury, even whether it was called abusive or not. But if you look at here, if you look at this, so this is the highest 5%, it's about like tenfold difference about predicting going to the emergency for an injury that was abusive. And again, then they looked at self-inflicted injury and also a tenfold difference, which I think is impressive for sure. And then they looked at differences between Black kids and non-Black kids, and actually some biases were picked up with this. I think this is a very thoughtful, important study. And so take a look at this if you want to. As a good example, again, one of the things that we're trying to do is have a tool that's not only categorizes someone based on prediction of maltreatment, but what you can do to reduce that risk. And that's what I want to talk about next. So last session, I talked about the modeling process for a study of the study of risk for maltreatment exposure in children between the ages of 5 and 9 from the Fragile Family data set. We talked about that. We talked about our model, and this is based on information from before the child, from 5 and younger. And this is our team who conducted the study. And I showed you this basically telling you about the Fragile Families data set. And we looked data at over 3,000 kids, over 1,600 variables, and it's distinguishing 9%, 292, who met criteria for maltreatment exposure versus the 91% who did not. And our predictive models are distinguishing that. And we have an AUC of 0.96, as I said last time, for those of you who don't know, is astonishingly predictive. An AUC ranges between 1, which is perfect prediction, and 0.5, which is totally random. And so 0.96 is very predictive. And we're also looking at most parsimonious predictions. So we were able to find with Markov boundary feature selection 15 variables that were as predictive as 1268. And then, as we talked about, we found with causal data science methods about 40 causes that were within 2 steps for maltreatment exposure, and with unconfounded effects, winning with large unconfounded effects. And then again, now we get into, we take the model, stakeholder input. I've already talked about this. This is our team wrestles with this to build that tool. And so today, what I want to talk about is that wrestling for us to get to the tool. So there's a lot here, and I don't want to go over everything. But this is the information that our team uses to build this tool. So these are different causes and different categories. This is ways of looking at how frequently the cause would be in the population we're interested in, which is child welfare prevention population. So I don't want you to pay too much attention because it's a lot, but I'm just showing you the data, the kind of how the data is presented as our team then looks at it and figures out which causes to choose, which have large enough effects, which could be measurable, which will have interventions available. So many causes here. Again, we have information on the size of effects. And so our team with the Champ Center, and we have a translation team. And on this team is, people who are scientists, are administrators, are clinicians, are family members, and we we need that diversity to take these results for the causes and distill it to what we think will be most relevant, including choosing interventions that will be helpful. Now, you should know we have not finished our work for sure, but we've made a lot of progress with this. And I'll just show you some of where we are with it. So basically, we could look at what we're calling 6 actionable causal groups. Their different causes seem to point to the same sort of problem, which has an intervention that we could think about. So, exposure to family violence is a group, but you could see the different variables that made this up. And then we have an odds ratio to tell us the sort of risk. And then we wrestle with coming up with an intervention for it. And so so we have the causal groups are exposure to family violence, maternal negative attributions of child behavior, exposure to corporal punishment from mother or father, whether the father has a vocational disability related to a mental or physical condition, whether either mother or father have anxiety or depression, and whether mother had, actually it was alcohol abuse, not substance abuse. So you could see if the description is the variables within it, and odds ratio is the effect size really. And then this is very preliminary as we're just throwing around ideas about intervention. PC care is based on PCIT, which can be used frequently and much more often than in PCIT. So a lot to talk about with that. We're just again, I wouldn't take the interventions put here too seriously because right now we're in the process of wrestling with this. We've more or less recently come up with this schema, which would then be programmed into the tool. And we're in active discussion with the translation team in order to finalize it. But for the presentation today, I wanted you to just see where we were, just to appraise the practicality of what we're after here. And so this again, the 6 actionable groups are here, each one with a different intervention. Again, remember I showed you like this toy model with self-destructive behavior from sexual abuse. It's like you're programming in per cause what is the intervention. And I'll just quickly show here there were causes we didn't pick for various reasons. Here are examples. The effect wasn't large enough, or it wasn't sufficiently intervenable. The population affected wasn't big enough, so it was too few families it would affect. We decided, because it's a maltreatment pub, not to include previous maltreatment episodes. Child welfare decisions, we didn't make intervention targets. And then there were some variables that we might have picked, but they, for various reasons, didn't meet the cut because we have to have a practical number of interventions. And we chose 6 here. So remember how decision support tools are designed to work. We'll call this the maltreatment prevention decision support tool input. We come up with an assessment package based on these 6 causal groups. It goes into a design decision support tool programmed to as output based on what the child and family says on these 6 things. What's their level of risk and need for intervention to prevent maltreatment exposure? And these are, again, families 0 to 5 for episodes of maltreatment older than 5 or 5 and older. What are the recommended interventions, and how much do we estimate the risk would be reduced based on that? And so, again, I've showed you this. And I'll just give practical examples here about 3 families that might benefit from this tool. So the first family is a family with a 3-year-old daughter determined to need child welfare preventative services following an investigation prompted by a mandated report filed by girls' daycare teacher. At pickup, child's mother was observed to be argumentative with staff, harsh with child, had slurred speech, and smelled of alcohol. So let's say this tool was used and, maternal substance abuse or alcohol abuse. And let's say in the assessment, you also picked up maternal negative attributions of the child's behavior. And then that would give us the output that I was talking about. Another family, for example, a family with 4-year-old son determined to need child welfare prevention following an investigation prompted by mandated report filed by police after being called to the home for domestic violence twice in 1 week. So here, exposure to family violence, and then let's say you do further assessment and you find out the father is home with a disability, a vocational disability, can't work, and let's say you find that mother was depressed because it's either mother or father's anxiety or depression. And that's going to give you an output with recommendations. And then another family, for example, family with a 5-year-old son was determined to need child welfare preventative services following an investigation prompted by mandated report by the kid's primary care pediatrician, who observed bruising consistent with handprints on the boy's physical exam. The boy's mother admitted slapping the child to teach him respect. So here we have exposure to corporal punishment, and let's say we assess this and had maternal negative attributions. So this is how it would work. And I'm not going to actually demo the tool. I could, because we have a workable draft tool here, but you see what each of the 6 causes. You would do your assessment and you would determine yes or no. You would click that, and then this would tell you, based on this, what the pre-treatment risk would be. It would spit out the intervention, and then it would spit out what you would expect the reduction in risk to be. The model we've built, it's a workable model here, so you could vary this and find out the differences, is like a basic first draft that we wanted to have just to figure out, is it workable? How would it work? That sort of thing. But there's a lot of more detail and more sophisticated answers that we're going to get from this. And then I think it's time to kind of end our training series. And I want to end it as I began it, like with this picture. This is our true north, why we are here. And so for all the science we do, for all the clinical practice we do, and the procedures we do, the interventions we offer, the assessment we do, it's all here. And it's all about figuring out how we're going to arrange to help improve their lives, give them a chance at a better future. And with that, I'll thank everyone for your attention throughout this training series, and we're eager to get your feedback to improve it, and also to see what you may be interested in next. So we could stop it here, and I'll just stop sharing. Okay.
First of all, if anybody has any questions, please jump in and ask them. One question just to get us started is if you're a clinician sitting in an office and you don't have a decision support tool, Glenn, could you talk a little bit about how you might use some of these concepts from this training series to think about how to approach interventions with kids and
Yeah.
families you might be working with?
Well, I think as we've said from the beginning, because I frame this in terms of care, nothing is relevant without it, that it's all about prediction under intervention conditions, everything we do. So we we sit down with a child and family, we decide what information we need from them, and that decision comes from somewhere. We use that information to ask ourselves, well, two questions. One, for anything I might be worried about what would happen to this kid, are they at risk for it? Are they at risk for maltreatment? Are they at risk for self-destructive behavior? Are they at risk, for anything? And let's say they have some condition, like you think they have depression or post-traumatic stress disorder. Well, are they at risk for continuing to suffer? Or do we think it'll go away without intervention? Or do we think there's a big functional implication that they're dropping out of school or going to use substance, whatever that is? So it's all about the future, all of us. And then it's all about, we're predicting, we're doing this anyway. We can't practice without this. And then we'd say, okay, they're at risk if we believe that, and we decide what to do, how we're going to intervene. That's what we do. The moment we do that and recommend that, we're making a prediction to ourselves that we communicate to the people we're with, that things will get better if you take my recommendation and we do this intervention. That's what we do. So one, to answer your question directly, Andy, it's for us to always be mindful of that. And if we're mindful of that, it allows us to think, do I have the best information I can to make these predictions? So what might I read about in the literature to help me? And that may or may not be helpful. But then it's, well, let me be disciplined enough to, if I think something it should get better in a week, 2 weeks, a month, that I've made this prediction, let me see whether that happened, and then let me adjust what I'm thinking based on that. Have I missed something if my predictions were wrong? So did I not assess this family to get the right understanding that guided why I chose an intervention? Was my intervention not strong enough? Whatever it might be. So, I mean, the take home message is to to use this to ground clinical thinking, but also to, you know, demand from our science something more useful than it's been, and to show, we're talking about clinicians, scientists are in the audience, you know, we wanted to show the needs is framed from the person, the kid, the family. So for scientists in the group to think, how will your science help inform this to translate to decisions that practitioners make? So I guess that's my best answer to your question.
Thank you so much. So other questions or thoughts about today's session, and then we'd love to hear from people about the future as well. All right, well, I think we've reached the end, Glenn, and I think we really, for those of you who stuck with us for all 6 of these, we really appreciate it. For those of you who have come and gone, we appreciate you as well. You'll be hearing from us very soon. We will obviously send out the slides and the recording of this webinar and all the other webinars after our training today. Our website's going to go live soon, and they will all live there, so there'll be an easy to find place for that. And then look forward to hear from us in the fall for likely the announcement of another series of training. So I really appreciate everybody taking the time to join us over these last 6 months. It's been a learning experience for us and hopefully for all of you. And we look forward to seeing many of you in the future.
Okay. Thanks, everyone.
All right. Take care, everybody.